to another. Oh, there it goes. Welcome everyone to another multidisciplinary trauma conference. I'm going to keep this short just because I'm losing my voice and it sounds awful right now. So we have Andrew Bowman. He's coming from Emory. He's an anesthesiologist and intensivist there. And he is going to talk to us about burn and burn shock. And with that, like I said, I'll keep it short. Andrew, the floor is yours. Thank you
Awesome.
very much for doing this.
Yeah, thank you again, Justin, for having me. And again, happy that we're kind of having a wide range of listeners here because what I'm going to talk about today is a little bit ICU care. It's got a little bit of ED care, a little bit of OR care. And I think it's kind of broadly applicable. And so again, I'm Andrew Bowman. I'm from Atlanta, Georgia. I primary clinical roles at Grady Memorial Hospital. Yeah, which is Atlanta's level one trauma center and the primary burn center for all of North Georgia and kind of somewhere a little bit into Alabama, southern Tennessee, that type of stuff. But Emory University pays my salary, and so I also have a assistant professor role there. My kind of my 100% of my clinical role is caring for patients with acute traumatic injuries. Um, Today, we're going to talk a little bit about kind of a review of burn injury physiology. We're going to discuss some of the little bit of a controversy of current research in burn resuscitation, and then we're going to focus on some of the cardiac changes and potential echo changes in the severely burn injured patients. So I've got no disclosures to report. And we'll kind of breeze through these initial slides. You guys are familiar with this. You know that there are burn injuries are relatively common in the U.S. About 1 in 100,000 or 1 in 10,000. This information comes from the American Burn Association, which the other ABA for anesthesia. We know it as the American Board of Anesthesiology, but we also have the American Burn Association, which produces some of this information. The Southeast is overrepresented in these kind of regional statistics, and so we do see a reasonable amount of burns. That includes Georgia. I think there's a lot in Florida as well, specifically in the Miami region. Um, a lot of us have had friends or patients, family members, colleagues that have had burns in the past, and these are debilitating, and they come with often acute other traumatic injuries and kind of longer term effects. So. Uh, there's about 6,200 hospitals in the U.S. 135 only have burn centers, and of the 135, 50% are certified by the ABA. There's a burn injury summary report that's produced by the ABA every year, which in 2022 had about 30,000 admissions. But we had 700,000 claims in 2020, and that includes ED, that includes admissions. And so this is the relatively large population, and with sometimes severe injuries. And A lot of burn care occurs at non-burn centers, and so this information is important just not only for our patients or our providers that work in trauma centers, but also in kind of the community. Luckily, fire deaths have been improving over time. Since between the 80s and the 2022, we've had a kind of decrease in the number of fire deaths, and the same time frame, we've had kind of an increase in the population. But that being said, overall mortality is still about 3.3%. For anesthesia, it's kind of close to the probability of getting a wet tap in an academic center. So about 1 in 20, and with about 26% mortality rate for cases involving inhalational injury. Um, so kind of what do these admissions and injuries encompass? Again, just kind of glazing through, you guys are familiar with these. So burn types, we have acute thermogenic injury. That's the most common thing that we would think about. This could be, house fire, it could be car wreck, oil burns. And these patients often have smoke inhalational injury, which makes them significantly more sick. We have electrical injuries. This could be like we have a guy recently at Grady had a major electrical injury on the job as an electrician, but you also could have something like lightning strike, um, radiation burns. When I hear radiation burn, I think of like a Chernobyl type situation, but much more common is like a severe sunburn. Chemical burns. Atlanta had a big chemical fire in a big kind of chemical plant recently that produced a few chemical burns there, and then these can be particularly severe. And then finally, kind of a forgotten, and at least in our burn center, we treat other types of epidermal destruction, such as Stevens-Johnson syndrome, toxic epidermal necrolysis, and then even like a hidradenitis. So burn care can kind of uh, encompass a wide variety of different injury types. And so, is this a burn center only problem? Um, the ABA does have criteria for transfer to a burn center. This is partial thickness burns greater than 10%, burns that involve kind of unusual areas such as the face, hands, major joints. So this would be areas that would be difficult to kind of to cover with skin grafts. Electrical burns, third degree burns of any age group, chemical burns, inhalational injury, and then kind of groups of patients that you may be difficult to treat in kind of another center. So this is patients with major medical comorbidities or other severe traumas. Uh, and um, and so kind of there was a group in South Florida that looked at these ABA criteria, and they looked at, this is about 2012, looked at the burn center care and the non-burn center care. They found that, there was a decent percentage of burn center or kind of burn care that occurred in non-burn centers. And so a lot of burns are being treated in community hospitals, and so this knowledge is kind of applicable to both our burn centers and then our providers that are maybe treating in kind of a non-burn center setting, because burn patients can occur anywhere. Looking a little bit about kind of the history of burn treatment. As you can imagine, burn advancements have kind of been associated with kind of world wars and kind of violence throughout time. The 1840s was kind of the hallmark of our first burn center. That was in Edinburgh. In the 1870s, we actually had skin grafts and saline infusions. As you can imagine, in the 1940s, there was a significant amount of burn injuries. And so those were kind of major advances in burn care, including kind of the late 1940s, early 1950s. You kind of had those rule of nines. Um, One thing kind of missing from this chart is actually in the 1970s, which is the advent of early excision. Um, and kind of early excision really revolutionized burn care in terms of kind of preventing long-term morbidity. And coincidentally, or maybe not so coincidentally, this coincided with modern blood banking. Um, as we all know about, burn care in the OR lead to pretty significant blood loss. And so, you really need modern blood banking to kind of care for these patients. Just a brief review of the burn injury timeline. We have an initial injury. These patients undergo an initial resuscitation. They get the burn tissue is essentially dead and has to be excised, and then that area is grafted with either kind of skin graft or a skin substitute. Um, and the timing of this is relatively important, as a burn is essentially a dead nidus for bacteria and inflammatory mediators. And so early excision is helpful in both reducing systemic effects, reducing morbidity, and accelerating healing. Um, and we're going to kind of discuss later that there's been a push for earlier and earlier excision, and there may be some kind of concerns with that, but I think that early excision is has been shown to kind of be helpful for patients long term. Just kind of historically, looking at burn injury physiology, this was initially described by a guy named Cuthbertson. This was again in the 1940s when, as you can imagine, there was a large amount of burn injuries in Europe. And he initially described an ebb phase and a flow phase, with the ebb phase being in kind of the 12 to 48 or up to kind of 72 hours after initial injury, and the flow phase lasting kind of days to weeks to potentially years after injury. And this is primarily seen in patients with major burns. And so when I say major burns, again, kind of what am I, how to define that? So that's going to be defined as major burns as greater than 20% total body surface area. And that's where we're going to start to see kind of these systemic effects. The ebb phase, we're going to have kind of a massive hyperinflammatory response. We're going to have a dysregulation of the coagulation and fibrinolytic cascades. And then vascular endothelial damage and dysfunction, leading to kind of this endotheliopathy of burns. And this leads to kind of a significant tissue edema in tissues not just that are burned, but throughout the body. There's also can be significant cardiac dysfunction, systolic and diastolic, which we'll kind of discuss further. The flow phase is a continued inflammatory response, but is more of a hypermetabolic response with increased oxygen requirements, catabolism, loss of function, and then potentially metabolic exhaustion and death. Um, this is combined with decreased oxygen delivery, often due to ARDS, inhalational injuries, um, and pneumonias. And this is treated by excision, grafting, early feeding, and then there are some hormonal and adrenergic antagonists to help attenuate these responses. Today, we're going to spend most of our time focusing on the ebb phase, with the kind of a little bit of drifting into the flow phase, but primarily ebb phase. There was a kind of a paper that came out in 2015 in anesthesiology, which we kind of have linked here, that looked at just the general kind of perioperative care of a burn injured patient. But they had a good couple of figures looking at these kind of physiologic changes in both the ebb phase and the flow phase. Kind of a couple of highlights. Here in the ebb phase, there's a decreased cardiac index, decreased stroke volume, potentially increased SVR, and then on echo, we kind of have small chambers, decreased contractility. We may have diastolic dysfunction, um, a variety of effects for cardiac wise. There may be ARDS, especially in the setting of lung injury, and importantly, we have a significant fluid loss through this burn skin and generalized edema, especially in kind of these severe burns, kind of greater than 20% body surface area burns. Uh, in the flow phase, again, this time we have kind of an increase in cardiac output and cardiac index, subclinical myocardial dysfunction. SVR actually decreases, and so it's kind of more of a vasodilatory type, not exactly a septic shock, but kind of similar to a septic shock. Um, High oxygen consumption, high CO2 production in the setting of potentially lung injury. So decreased oxygen delivery and decreased ability to get rid of CO2. Um, and then kind of this muscle catabolism and persistence of that generalized edema. And so it's important for our anesthesia providers to kind of be aware of this, especially these issues with the lungs, with kind of the oxygenation and CO2 production. And so to ensure that we maintain appropriate respiratory rate, tidal volumes, and PEEP in the OR. Um, and so, kind of, we have a variety of physiologic changes that kind of sum up to create burn shock. Um, and so, burn shock is a kind of a loss of intravascular fluid, and this results from a shift of that intravascular fluid to the interstitial and intercellular spaces. And so, burn shock is a hypovolemic shock, but it's fundamentally a form of a redistributive shock. And this is entwined with accumulation of the interstitial fluid and intercellular fluid and significant tissue edema. And so the dilemma is, burn shock resuscitation requires significant amounts of specific volumes of IV fluids. And while life-saving, this just worsens the edema due to those hydrostatic forces. Under resuscitation can cause organ failure, such as AKI and death, but over resuscitation can also be damaging. And so, we have intravascular fluid loss, we have an increased SVR followed by a decreased SVR, and this is combined with reduced myocardial contractility. This is due to this catecholamine and inflammatory mediator surge, and there's kind of two arms here. There's this decreased preload arm, which is due to that endotheliopathy of burns, and then there's also this arm of reduction in myocardial contractility. This is interleukin and driven by other inflammatory mediators. The myocardial dysfunction is characterized by both reduced contractility, also slowed isovolumetric relaxation or kind of diastolic dysfunction, decreased left ventricular compliance. And both of these in combination lead to that decreased cardiac output and potentially end organ malperfusion. And so in general we have a reduction in that cardiac output, and this is again an interplay of hypovolemia, so again preload problems, increased SVR, followed by decreased SVR, decreased contractility, and then decreased um, coronary blood flow. And so what we have is kind of a complex, um, uh, difficult to treat shock, just due to this kind of multifactorial causes. And again, we have distributive, we have hypovolemic, and we have cardiogenic shock, kind of all in combination. Um, so to, how do we overcome this shock? Initially we give patients crystalloid resuscitation. So when I started doing a little bit of research here, I discovered that there was a variety of resuscitation formulas. But the two that we may be most familiar with are the Parkland formula and the modified Brook formula. And just in brief review, Parkland formula, we have in the first 24 hours, we're going to give 4 mLs per kg per percentage body surface area burned, which we give give half in the first 8 hours and the remaining over the next 16 hours. In comparison, the modified Brook, we give 2 mLs per kg per percentage body surface area, one half in the first 8 hours and the remaining half in the next 16 hours. Uh, and both of these formulas allow for colloid for kind of assistance, and used urinary output as kind of the end goal. So the ABA has resuscitation guidelines, which they produced this was written in 2008. And they had a variety of recommendations. One of the major ones is, any patient with a severe burn, so greater than 20% surface area, should get formal fluid resuscitation. This is usually using a table. And there's common formulas, either 2 or 4 mLs per kg. And we're looking for titrating to urine output. And they say that there may be increased volumes required in patients with full thickness injuries, inhalational injuries, delays in resuscitation, or kind of other complexities. And so, kind of here's one sample resuscitation algorithm that is often used. We kind of use this as the basis for ours at Grady. This is primarily nursing driven, um, and uh, and again, our end goal here is urine output. And I when I started kind of doing a little bit of research on this, I was kind of like, why urine output? Why not base deficit? And base deficit and lactate does have a place. It's not entirely supported by the literature yet, but I think that right now urine output is our primary end goal. Um, and and when we look kind of back here at the physiologic changes, that oliguria may be common in that kind of early period, and maybe a sign of a under resuscitation. But there are patients that using urine output may be difficult for resuscitation. Say heart failure and stage renal. And there are guidelines by the ABA for difficult resuscitation. They highlight patients that may be difficult to resuscitate, including associated traumatic injuries. So, these patients may need blood. Patients with electrical injuries, inhalational injuries, very deep burns, specifically methamphetamine fires, and then patients with severe comorbidities that may kind of obscure the common urine output guidelines for resuscitation. There was a group out of Fort Sam Houston. This was 2011, looking at kind of difficult resuscitation, and they still say that urine output is the goal, but we can add albumin. We can they do mention CVP, that may be a kind of more of a 2011 recommendation. We kind of drifted away from using CVP for volume status. But they do note that the goal here is to minimize fluid administration while maintaining organ perfusion, and that's kind of the goal there of of tracking urine output, is to ensure that we are getting organ perfusion. I did want to note kind of number two there on their table is to check bladder pressures every 4 hours. And so why would we be checking bladder pressures? This kind of opens the door to kind of one of the controversies, and that's the controversy of kind of fluid creep. And so sometime in kind of the 2000s into kind of modern age. And we've had this idea of kind of fluid creep in burn resuscitation. And the initial question in this discussion was, is the Parkland formula correct? We have a Brook, modified Brook, we have a Parkland formula. And the Parkland formula is like as a godfather formula. It's every medical student knows this. Every resident knows the Parkland formula. They know the rule of nines. They can kind of it's been tested on step one. And so it's kind of hard to challenge something that has been around for that long and is so accepted. Um, and so Saffold kind of had took a look at this and did a little bit of a review and found that a lot of these patients were actually exceeding Parkland requirements. And so while we were our goal was for cc's per kg per body surface area burned. Oftentimes we were giving more than that, and there may be some morbidity associated with these increased volumes. And so there was a 2007 retrospective cohort study looking at this is a multi-center study looking at the relationship between fluid resuscitation and outcomes following thermal injuries. Kind of just looking at the patient characteristics here. The first thing I always look for is, okay, what's the body surface area burned? And so these were all in the kind of severe burn range. Um, and kind of what they were looking at was, how much fluid did these patients get? Um, Table 4 here on the left, their initial Parkland score was 1.3. And so kind of a Parkland score is just the ratio of their received fluid to their kind of predicted fluid. So they also found that often their patients were getting more than they should be for the kind of the Parkland formula. And kind of looking here at their outcomes, there was a 25% overall mortality, which is kind of in line with the average. But I want to note here, kind of, there's about a 4% risk of abdominal compartment syndrome. And so we're thinking back to why were we checking bladder pressures in a patient that maybe have a difficult resuscitation? And this is kind of the severely morbid complication is an abdominal compartment syndrome. Um, but this group here, this multi-center study, they did find uh, that there was a significant increase in unadjusted odds for developing pneumonia, bloodstream infection, ARDS, and multi-organ failure and death, especially in these patients that got greater than 25% predicted for the Parkland formula. And every patient that had 25% predicted had at least one of these outcomes. So, this keys us in that the reality is over-resuscitation does have morbidity, and this is described in other reviews. We had a review of respiratory failure in pediatric patients that may have had scald injuries who may have gotten more than expected volumes of resuscitation. We have intercompartmental sepsis in burn patients as well. This is kind of from the early 90s. Um, and then, we have a larger review article looking at abdominal compartment syndrome. This was a 2006 review article, specifically in both the trauma and the burn populations. And Kirkpatrick looked at a variety of studies, and we see here that there's some of these studies were burns, some of them were trauma with kind of some burn injuries. And we had a high a rate of abdominal compartment syndrome, and the reality is that this abdominal compartment syndrome was relatively morbid, and kind of again makes us a little bit worried about over resuscitation as this um, giving too much fluid can cause a severe morbidity and potentially death. And so I've been talking a lot about the Parkland formula. I mentioned the modified Brook. Um, and so what about the modified Brook? Uh, these actually have been looked at head to head. So this was again, this was a 2009 article out of the U.S. military comparing Parkland with the modified Brook. So U.S. military, the primary burn surgical research center is in Fort Sam Houston, Texas. And so it's the primary burn center for active duty personnel in the Department of Defense. And so this occurred in the Iraq and Afghanistan wars. And so military burn patient or casualties were transported from Iraq and Afghanistan with a stop in Germany over a period of kind of 3 to 6 days. To get definitive care in Houston. Uh, So they kind of had two arms there. They had a modified Brook arm, they had a Parkland arm, and they had asked deployed providers to pick kind of one of the two arms and titrate to urine output. You know, they're pretty even. When we look at first base deficit there, modified Brook may have been a little bit sicker to start, but relatively even. And so when we kind of look at the amount of fluids that they received, would expect the Parkland formula group to get more than the modified Brook formula group, and we did see that. And then when we look at kind of clinical outcomes, there was no significant difference in clinical outcomes. Uh, so this was ARDS, this is AKI, abdominal compartment syndrome had a percentage of morbidity in kind of both groups, and there was a 18 and 14% mortality. And so maybe one is not superior than the other. And that being said, and when they actually went and looked at the amount of fluid given to these patients, it turns out that the modified Brook group got kind of closer to a Parkland formula um, volumes, and the Parkland formula group got closer to kind of a 6 mLs per kg volumes. And so it didn't really fully answer the question. So what about a restrictive grouping? And so there was a 2011 multi-center prospective cohort study looking at kind of three groups. There was a restrictive group, so less than 4 cc's per kg, kind of a standard group, which is 4 to 6. So maybe we'll say that's kind of a Parkland-esque group, and then a excessive, which is kind of greater than 6 cc's per kg. And they were primarily looking at the restrictive group. And their primary outcome they found was the restrictive group was associated with an AKI, and so they made the claim that we maybe should avoid doing this highly restrictive uh, um, type resuscitation, and this goes along with the goal of urine output with burn resuscitation. And so we kind of have the dilemma here, and so the dilemma is inadequate resuscitation leads to organ failure and death. Global microvascular permeability leads to edema, and so we need to resuscitate these patients, but this global edema can cause abdominal compartment syndrome. It can cause extremity compartment syndrome, wound healing issues. And then the resuscitation with IV fluids can worsen that edema, but is required for life-saving care. And we can't often use our normal guidelines for resuscitation, such as blood pressure and heart rate, to help guide this burn resuscitation, as blood pressure cuffs are often inaccurate. We have sometimes kind of a higher SVR, and so blood pressure may be actually elevated. And then the heart rate is a poor indicator for volume status due to that kind of high sympathetic tone. And so we can have heart rates regularly in the 110s, 120s, 130s, inappropriately resuscitated individuals for days, weeks, sometimes months. And so in 2024, the ABA did actually release some practice guidelines regarding shock resuscitation. Um, the They answered a kind of asked a variety of questions, and I won't kind of delve into all of these, but some of the questions answered were, what should the starting rate be for crystalloid? Should we use albumin? Should we use colloid? Should we use FFP? Are there other parameters that can be used to guide resuscitation, including CVP, transpulmonary thermal dilution, stroke volume variation, or pulse pressure variation, trending lactates, or trending base deficits? And so, just to kind of quickly answer some of these questions, their recommended starting point for crystalloid resuscitation is 2 mLs per kg per percent body surface area burned. And this is what we do at Grady as well, is we start at 2 and often increase. Um, should we use albumin? As needed for difficult to resuscitate patients. But I would find in our institution we use a little bit more FFP than albumin. Just some of that's we give a lot of blood at Grady, and that's just kind of our institutional habits. But FFP does have a place as well as albumin. And then should other parameters be used to guide resuscitation? So CVP did not really was not very helpful. Transpulmonary thermodilution didn't really wasn't supported in the literature. Stroke volume variation and pulse pressure variation, maybe. So I think kind of the jury's still out on that. And then some sites trend lactate or base deficits, and we do that on occasion, but we as a kind of to help trend end organ perfusion, but we don't do this in every case. And so we kind of think back to our kind of our two arms of our burn shock. Um, we have that upper arm, which is decreased preload, and so we treated that by uh, resuscitating patients with crystalloid to help increase that preload. The other arm to this burn shock is myocardial contractility issues, myocardial depression. So now let's kind of turn our eyes to the lower arm of this burn shock. So in kind of the 1970s, there was a landmark paper by Pruitt, again, Fort Sam Houston, Texas, looking at cardiac output and SVR. He found that kind of this initial period, especially in the kind of the 12 to 24 hours, there's a significant decrease in cardiac function and stroke volume in that initial period. SVR is up and then as becomes persistently down over those kind of days to weeks after that initial burn injury. Kind of the next paper we're looking at, this is a paper out of Europe. This was in 1984, College of Surgeons of England. It was a cohort of 15 patients, and I actually found this study very interesting. They looked at a wide variety of patients, and then they looked at cardiac output, they looked at stroke volume, and they looked at heart rate. Uh, and we kind of look at their ages and their percentage body surface burns. They're almost all of them are above that 20%. But we have a kind of a 15-year-old male here with a stroke volume of 25. We have a 24-year-old male here with a stroke volume of 15 mLs. So these are, this is severely depressed cardiac function in a patient that really should have kind of a normal heart. And so, um, I hadn't realized when I started researching this how severe that cardiac depression can be. And when we look kind of here on the left there, case number 9, that stroke volume, it starts in decrease. It starts in day 1, but it lasts to day 2, day 3, and it doesn't really fully recover. Um, and and this adds a little bit of a concern to kind of when are we starting the excision on these patients? Early excision does have a place. And it is supported by the literature. And so 2023 there was this is out of Florida. And we were looking at a burn excision within 48 hours leads to better outcomes. And this is kind of our habits at Grady. So they found they kind of had two groups with a reasonable size or very good size I would call it of about 1,000 patients and relatively well matched. And they found that's a subgroup analysis looking at the groups with greater than 20% body surface area burns. They found that these patients, early excision, kind of within 24 hours or less, were associated with shorter length of stay, shorter ICU stay, decreased rates in deep vein thrombosis, all venous thromboembolism, catheter-associated urinary tract infection were all lower in the early excision groups. There was no difference in PE, pneumonias, severe sepsis, ARDS, or mortality, though. Um, but this kind of does, the longer the patient's in the hospital, maybe the higher risks, and so this has some support to the early excision argument. And so, I know this is a multidisciplinary group, but how can anesthesia contribute to this? So we know we have a cohort of patients that are potentially unstable. We have patients who may be hypovolemic. They may have systolic dysfunction, and they have a need for early excision as this may improve their length of stay, their ICU time, and kind of get them back to their normal life as sooner rather than later. And all of this can lead to intraoperative shock. And so in anesthesia, we have a rise of providers who are skilled in kind of a variety of modalities, but particularly with echo. Um, and there may be a role for kind of anesthesia to start looking a little bit closer at these severely burned injuries and kind of the pre-op or the kind of the risk assessment phase of the maybe in the 24 to 48 hour after initial injury time frame. And so, there have been some groups in the past that have used echo to kind of improve outcomes, or that was more less so improve outcomes, but kind of more so to um, uh, look at systolic function prior to going to the OR. So this was a group in 2013 looked at transesophageal echo data, 40 patients. It was performed by a cardiac anesthesiologist. Um, there was a variety of indications, and that include inotropic need for inotropic support in the first 24 hours, enlarged cardiac syllabite, significant pulmonary edema on chest X-ray. And so, they weren't specifically doing these exams as a pre-op assessment. Um, they found that there was a large group, about 62% of these patients had um, systolic dysfunction. And again, this is a pediatric group, so these are not. This isn't your 80-year-old grandma who kind of got in a house fire. No, these are assumed otherwise health or previously healthy children. So we had 60% that had cardiac dysfunction. Uh, they had a decent amount of group patients that were on pressors. And interestingly, this was not associated with the patient's ejection fraction. So it was about 50-50. And they did find that that this association with decreased systolic function was associated with increased ventilator time, increased ICU time, and increased length of stay. And so trying to identify these patients earlier may help us help triage and keep a closer eye on patients that have this systolic function, because overall they're the sicker of the burn population, which is a heterogeneous population. There's another 2014 review article. This is again looking at transesophageal echo and the management of burn patients, and they looked at a variety of studies. Um, with usually smaller cohorts. But I found it interesting that kind of when we looked at all of their echo findings, some of these patients had systolic dysfunction, some of them had diastolic dysfunction, some of them had kind of filling issues or signs of hypovolemia. And so overall, this painted to me kind of a picture of a variable picture. So if you echo a burn patient, you're not exactly sure what you're going to find. And but that being said, the intraoperative management of these different findings could be variable, and having some knowledge of this patient's function prior to going to the OR would be helpful. And they do make some suggested indications and hemodynamic monitoring, diagnosis of cardiac infections, and diagnosis of cardiomyopathies. Um, I found this study very interesting. This is a 2003 paper out of Scandinavia. There's only 9 patients, but almost all of them had severe burns. Eight out of the 9, they had 2 deaths. I found this interesting because they were looking at they had TEE, and then they also had a PI catheter, and so they were kind of looking at some of the functional studies for that. They found low CVP, and then they also had a kind of low pulmonary arterial wedge pressure. And so this was interesting because these patients were, in theory, appropriately resuscitated. And so they made the claim that these patients had good urine output, but on echo, maybe they were volume down, maybe they were under resuscitated. And this may key us into the fact that echo studies could be helpful to assist with resuscitation in these kind of maybe potentially difficult to resuscitate patients, as maybe whether you're cardiac failure or kind of renal dysfunction, where we need a little bit of extra piece of information there to help us key in on what the volume needs are for those patients. And then kind of finally. This was a 2010 retrospective review. Again, it's out of University of Utah. And they did a variety of TEEs were performed. I reading the paper, I wasn't really able to discern when the actual TEE was performed. My inference was that it was done in the ICU. Um, and they've had a variety of findings here, mostly hypovolemia, small pericardial effusion, right heart failure, fluid overload, uh, and but they did not really have a ton of therapeutic interventions there. Just started dobutamine on one patient there, um, cardioverted on another, and they do note that that in most situations the fluid resuscitation had already begun when the TEE was performed. Um, they do note that that burn shock resuscitation was not the focus of their review, uh, but this may be use of echo in burn shock resuscitation may be an important future direction. And so uh, septic shock may be a guideline, and there are have been reports of echo being used to assist with septic shock resuscitation, and there may be an opportunity here for the burn team. And so kind of when we think about burn shock here, we have the time zero burn injury, cardiac function, volume status. So in that first 24-hour period, we're going to have decreased cardiac function, and I assumed decreased volume status until the patient is appropriately resuscitated. As we push more and more towards a less than 24 hour, for that less than 48-hour early excision, that cardiac function may not have been recovered, may not have fully recovered. And that volume status, we assume that we've reached that euvolemic state, but it may or may not have gotten there. And there is a place for echo to help with that resuscitation, with that diagnosis of that cardiac disease, um, for this potentially, or not potentially, rather morbid procedure of a burn excision with significant volume swings. And then when we think kind of in more the days to weeks period, we're going to have repeated excision and grafting, and this may be in the setting of ARDS, sepsis, DVT-PE, and again, kind of there's a kind of unclear what the volume status will be in those situations, what the cardiac function will be, and this could use kind of more of a future scrutiny. So I'd mentioned sepsis as a guide. There have been kind of some reviews looking at sepsis as a monitor, and they are at echo as a monitor for sepsis, and I think that especially with the rise of point of care ultrasound, the burn team, those of us that do trauma, may want to consider using this as an additional tool, both looking at left to right sided filling pressures, LV and RV function. You can potentially have to use dynamic measures such as preload responsiveness, um, and cardiac output, stroke volume variation, pulse pressure variation. And when we think kind of about what kind of skills do you need for kind of a POCUS or kind of an echo assessment of these burn patients, it's kind of in this range. A little bit above cardiac POCUS, maybe a little bit under critical care echo, but we're getting more into the critical care echo type range. Where we're doing some quantification. We're doing this due to a clinical status, and we're usually doing it under medical necessity due to kind of some concern for hypotension or as a pre-op assessment. So are we actually able to obtain the images? So this is one of our, actually, luckily, I just discovered this week, this guy was recently discharged. And so he's got we had many echoes of him. This is him kind of late stage. He's got a very dilated right ventricle there on the left, and had a few VTAC arrests, but he was discharged from the hospital this week, greater than 80% body surface area burned. And so we are actually able to obtain these images. And sometimes you may have to remove dressings. They make sterile probe covers. Um, and and uh, and the reality is, when you remove a lot of soft tissue from the chest, sometimes it can make the images better due to the kind of a decreased distance. And so we may be able to use this echo to help guide resuscitation. Um, we have a couple of papers out of this. These are a couple of my colleagues at Emory who have produced a couple of papers on perioperative applications of focused cardiac ultrasound, and looking at what modalities you may need for checking these volumes, the volume status and the flow function of these patients. So here, just to highlight a few. A patient that is volume overloaded will kind of have a dilated non-collapsible IVC, RV enlargement, RV dysfunction. A little bit more of an advanced finding would be kind of high left atrial pressures. Uh, Here, that's kind of again unpacking this a little bit more. Systolic function, we're going to have decreased motion. We're going to have low ejection fraction, decreased stroke volume on echo. Right RV failure is going to have enlarged RV, flattening of your interventricular septum, decreased TAPSE, decreased S prime. And then hypovolemic shock is going to be a small LV cavity size, low cardiac output, high ejection fraction, and a small collapsing IVC. Finally, diastolic failure, large left atrium. You're going to have changes in your E and E prime, changes in your transmitral Doppler patterns, potentially significant tricuspid regurgitation. Some of these are a little bit beyond kind of the classic POCUS providers, but they may be helpful for assistance in diagnosis. And so kind of we painted a picture here of you know patients that are a cohort of patients that are particularly sick, that have variable cardiac presentations, that have variable volume statuses, both pre in the OR and after the OR, and potentially a method to kind of improve their outcomes, and improve their survivability. And we're kind of reaching the end here. Just future directions. As I'm kind of suggesting here that TTE and TEE in the burn perioperative assessment may be helpful to help guide management. In my lit review, I really didn't find any publications looking at TEE or TTE in the kind of the in the OR, and really looking a ton at outcomes. So I think that's kind of an opportunity for improvement. There's some limitations, limited provider access or experience. Again, a variable of cardiac phenotypes can make diagnosis sometimes more difficult. Obviously, dressings may be obscuring our windows, and then there's kind of limited established research other than the studies basically I highlighted today. Um, when we think about kind of patients that are on these severe burn injuries and difficult to resuscitate, such as comorbid conditions or acute traumatic injuries. Addition of these modalities could be helpful to improve outcomes. So I think it's been about 50 minutes, and that's all I got. So I'll just kind of open the floor to questions, and then maybe get you guys out for a couple minutes early.
That's all you got. Andrew, that's wonderful. Thank you. It's always nice, with burn talks, it always talks about resuscitation. And I mean, I give a burn talk and it's all about resuscitation. And I'm glad, it's one of these things where you're right. We all know the Parkland formula, and yet I still feel like we need to review that resuscitation. But I'm so happy to see this go a different way, especially with the ultrasound, because it's really nice to see how that fits in to the patient management. We expect it should be very useful for this, but it's never talked about. So thank you for addressing that and kind of going down that path.
Yeah. Thank you guys for having me. I'm just looking through the chat for a second. So is excess fluid the cause of increasing morbidity and mortality, or is just a marker of severe illness? So yeah, I agree that is kind of a difficult to tease out. A patient that has a more severe illness, whether that's severe deeper burn or maybe an inhalational injury, often will get more fluid. And the um, you know, I think it's gonna. I don't have a real answer as to kind of what's cause and effect. I think that excessive fluids can cause morbidity or mortality. and that we need to kind of reduce the amount of fluid we can while maintaining organ perfusion. Um, and then Jennifer said mostly young men in military studies. Yeah, so that would be probably increased survivability. Um, and then Albert asked for PDF, and yeah, so I'll be happy to send out. I can send out a PDF, or I can just send out the slide with all my notes, so you guys can share them too with your residents. Um,
Yeah.
I'm make this open forum. The more everyone's willing to take this and run with it. So
Andrew,
Andrew,
I just want to mention something that I was not aware of, and I aware since our last burn center site visit. Everybody caring for the burn patients, including the anesthesiologist, must have CME on burns.
oh
So all of you that have a trauma center, write the time and the date because this counts like an hour for those 4 hours that you need. Because
yeah.
otherwise you're going to forget later on. So make sure you put a note of this. So when they come for site visit, the burn coordinator is going to ask you for your CME specifically in burn. So I appreciate you doing this.
Of course, and actually, with that in mind, Grady is not ABA certified, and, and one of our knocks this year was we didn't
Yeah.
have enough burn CME, and so that was kind of what started my interest in this.
Yeah.
And so we're up for review again, I think this year. But yeah. So please take the burn CME and I'm happy to share the slides. So
yeah,
Thank you.
Andrew, if you want forwarded on, we'll distribute it to the list.
okay, awesome. And then I think Grace, you had a question. I saw her hand raised.
Hey, yeah, thank you so much. That was really wonderful. And I apologize if this is too basic of a question, but I'm curious your thoughts on resuscitation with colloids like albumin and FFP and what Grady's practice is. Thank you.
Yeah. So we do resuscitate with both colloid or with both albumin and FFP. We are a little bit more heavy on the FFP, and it's actually a financial reason. We found that we just get a little bit more bang for your buck with FFP than with albumin. And I think I mean, I'm sure you guys all do. Everyone here that works at the trauma center gives a ton of blood. We have so much blood, and I think that part of the reason we give so much FFP is um, it's institutional, it's the habits more than anything else, and that's I think what led us a little bit more to the FFP over the colloid. But we primarily use it in patients that are you've given them what you think is the appropriate crystalloid resuscitation, and they're just not getting better. Um, and, and and I don't actually have an answer to this yet, but I do wonder if that shock may just be multifactorial, that it is just more than just a distributive shock, that there may be a cardiogenic component that's just being undiagnosed. And that's kind of what my personal interest is in echo in these populations, because I think that the shock probably is multifactorial, and we maybe should be starting a kind of a low-dose epidrip or some norepinephrine or something to kind of get a little bit more squeeze in these populations to kind of help with that resuscitation. Gabrielle, I think you raised your hand.
Yeah, Dr. Bowman, thanks for the talk. I appreciate it. I had two questions. I guess the first, and I'm so sorry if I missed this, but did you discuss the use of high dose vitamin C at all? And do you guys do this at Emory?
We do, and I did not discuss it, and honestly, I don't have a ton of personal knowledge with it, so I can't really speak more than that.
Okay. And then my second question, this is a selfish question, but we are currently in the process of trying to, I would say, more or less protocolize our approach to burn management at our institution
Mhm.
at Barnes. And I think one of the biggest challenges that we're facing right now is just how to operationalize this within our EMR.
Mhm.
Do you guys have, if I could talk offline with you, but just, I guess, any advice or any wins or successes that you had when trying to, I guess, approach this, when trying to protocolize this in the EMR, or do you guys sort of do something outside of that?
Do you mean maybe we can talk offline, and then
Yeah,
because I may be better, I'll connect you with we have our primary burn surgeon who is like head of the ICU, maybe better
excellent.
to answer that question.
Yeah, no, that would be
Um,
fantastic.
it's Laura Johnson. She's kind of cited on a few of these papers, and very happy to talk about it. And I can talk most about the interop stuff, and she runs the ICU kind of very well. And so
Okay.
additionally, we're actually building burn ORs by our ICU, and so that's something that if you guys have the funding, we're gonna kind of we're creating some ORs for these dressing changes, for these kind of easier excisions. And so, kind of hopefully if it goes as well as we hope it's going to, it'll be a kind of a model that other people could take. So,
Fantastic. Thank you so much. I appreciate it.
yeah.
I have a question related to that. Sorry. When you say you have like an OR related just for like dressing changes, is that do you have an anesthesia provider for that, or are the surgeons doing both the moderate sedation and the dressing changes?
Yeah, so we actually haven't opened them yet. They've been built, and we will have anesthesia associated with them 100% of the time. And the goal is likely for kind of like a anesthesia assisted kind of moderate to heavy sedation. And ideally we will do kind of the lower acuity burn cases down there. And then kind of we have a one burn OR where we'll do our large excisions. The main limitation of these new ORs is they're kind of far from the blood bank. And so we you know we're trying to avoid doing any of the major procedures down there. But anesthesia is fully involved in the kind of the general operations and the kind of the construction of these ORs. So, well, thank you, Governor Kemp, for some money. I think that's where we got some public funding. Any other questions?
Well, right at an hour. So, Andrew, thank you so much again. Wonderful talk. I'm sure we'll be talking to you about getting this up on the YouTube channel. So if anyone wants to review the slides or everything, like I said, we'll try and get those distributed. But you can also, you should be able to view this talk on our YouTube channel under Trauma Anesthesia Society. And that should be up in the relatively near future.